Hello, everybody. Welcome back to the Incubator Podcast. We're live at Hot Topics in Neonatology in beautiful Washington, D.C., and we are joined by Dr. Katherine P Callahan. Katherine, welcome to the program.
Thank you.
You're a neonatologist and a bioethicist at the Children's Hospital of Philadelphia, where your work focuses on how genetic information shapes decision-making for newborns and their families. You lead a K01 funded program examining how clinicians and parents interpret uncertain genomic findings. And today, you're presenting at Hot Topics on embracing complexity, genetic information, and neonatology. My first question is early in your talk, you said that the NICU is at what you define as a launch point for genetic technologies, but that the information we get is often more complicated than what is portrayed. So in one of your introductory slides, you emphasized that genetic information can be diagnostic, can be ambiguous, or even misleading. Can you walk us through how you think about genetic information specifically in the NICU?
Sure. I guess I'll take a step back and just think about like the overall goal of what I'm trying to establish and then get to that more specifically. I think genetic information, well, the NICU has been a launch point for genetic information for a number of good reasons, the most significant of which are that a lot of neonates who end up in the NICU have genetic disease. If they're not there for prematurity, they are there for something, and often the etiology is genetic. And we've shown with the advance of genetic technology that often we can actually figure out what the etiology is. And also in the NICU, I think as clinical neonatologists, people will recognize there's a really big need for prognostic information. We're often trying to figure out how is this child specifically going to do, and genetics promises to be one of those answers. And I think those are the biggest reasons that it's appealing. But in both of those realities, in first of all, figuring out why a child is sick and then figuring out what to expect for them, genetic information itself, the answers are often complicated. And then what we actually do with the answers is even more complicated. And overall, my research really stems from the idea that, like, if we acknowledge that complexity and kind of think about, wow, this is not as straightforward as some other health measures, that we're actually going to be able to do more good with genetic information. Whereas I think a lot of proponents of genomic medicine have thought that if we could simplify this so we sort of make it fit into the neat box of other kinds of technologies, like that do sort of in a more neat way decrease morbidity or length of stay, that's going to be what sells it. So I try and push back on that narrative in a variety of ways.
Yeah, you do mention also sometimes how the literature portrays data on genetic information, and that you even mentioned that sometimes it can be misleading because it can give the false representation that there's a lot of information that's actionable, but it's not always the case.
Yeah. I put in one of my slides for today this kind of graphic that I grabbed from a children's hospital website, but there's similar graphics on almost all children's hospital websites, which sort of depict precision medicine as like figuring out why this child is different so we know what medication to give them so their outcome will be better. And that's a very straightforward narrative, but that's not typically in my clinical research experience or in my research what is actually happening with genetic information. A lot of the time it's instead giving us information about the future, albeit with a great deal of uncertainty, and then it's up to clinicians and parents to sort of feed that back and figure out how that should and how that does impact our decision making in a day-to-day NICU stance.
Yeah, I mean, one of the points that you bring up, which is such a frustration point for all of us, is these variants of unknown significance.
Yes.
And I think that this is probably the more common reality of these patients that were like, I'm sure we're going to elucidate a genetic diagnosis. And we are returned by, there's something, but we really don't know what this is. And we're all looking at each other, be like, I don't know what to do with this.
Yeah, I think that's definitely true. And I will add that I think variants of uncertain significance are not sort of like a box that we can put in one area and resolve, because a lot of people are hopeful that variants of uncertain significance might actually go away, and it's possible with the advance of genomic technology. But even outside of those explicit variants, there's still a lot of uncertainty about whether a finding fits or what it means for a child or what to expect. There's not really a black and white line between VUSs and likely pathogenic. It's all blurred, right? Even clearly pathogenic findings, often we don't know what it means for an individual.
And so can you tell us, I want to press a little bit on what you just said. You said that the VUS, the variants of uncertain significance, might eventually go away. Can you explain to people why you say that? Because I think we tend to see this as an endpoint, but it's actually the beginning of a lot of work that is being done.
Yeah, so they might go away because we're developing much better genomic technologies to actually all kinds of like assays that honestly I'm not a genomic scientist, although I did take the PhD lab genomics course, so I have learned about the complexity without being able to resolve it. But there's all kinds of technologies to actually figure out which variants are pathogenic and disease causing. But even if we know that a genetic variant is disease causing, even if we know that it's the reason that the child in front of us is sick, we often don't know what to expect for that child. And this has been driven home to me in the NICU because we recently implemented a broad genome-based panel. So we've been testing a lot more patients, and we have also been testing their parents. And in a lot of cases, we've found, for example, that the parents have the same mutation as the child, but their presentation is so different. Like they're sitting there, a functional parent, and the child is almost certainly going to be quite disabled. And so it's just genetics is not a simple answer. And I think that's true even when findings are clearer in a lab sense, more clearly pathogenic.
Yeah, I could not agree more, and I think that this gets to one of the points that you made in the presentation about, I guess, informational hazard, and you end close to the end of the talk. You mentioned that genetic information can pose an informational hazard, specifically when we talk to families and the psychological, the ethical, and the decision making toll that this information takes on the team is sometimes underestimated. What are your thoughts on that specifically?
Yeah, I think medicine has generally operated from the stance that more information will be better, and we will know what to do with it. We'll figure out what to do with it once we have it.
Right.
And I think we don't always go back and think about like what did this information actually do, and how do we need to manage it? Maybe with some feedback to whether we actually get the information or how we kind of introduce it back to practice.
Yeah. And so looking ahead, I think that it's always very confusing when we're dealing with a lot of complexity and we're still sort of finding our footing in this
Yeah.
new reality. But what do you foresee the future of genetic testing in the NICU will look like maybe in 10, 15 years based on what we're doing well right now, some of the things that we're struggling with? What does the outlook look? What is it? What is the
Yeah,
outlook for that?
I do believe that we will test more and more patients. I think this is an unstoppable current and for good because there's a lot of good that comes from genetic testing. But I think that people will be forced to acknowledge that genetics is not operating in the neat and tidy way that we kind of expected. Like if we introduce genetics at genome sequencing, for example, in a more universal way, I don't think we're going to see length of stay decrease or mortality decrease. And then we'll have to say, okay, well, it's doing something else. And I'm hoping that maybe we'll have to acknowledge, okay, it's mostly informational. And then we have to think about informational benefits and harms differently than other types of benefits and harms. And a lot of that hinges on discussions with families, because almost everything to do with information is in the realm of shared decision making.
Yeah, it's very interesting because we've measured outcomes in a very typical manner in our field, and this might be the onset of maybe a new way of thinking of outcomes with this additional information, and maybe rethinking how we look at neonatology even beyond the NICU and looking more downstream.
Yeah, I mean, I'm even doing some work with consent now, and I think people really want to be able to make genomic consent standardized and have sort of like YouTube snippets that we just show parents. But I really believe that much of what parents want to know is like, how is this information going to fit into our unique situation? And none of that can be
It's
easily
hard to know.
kind
Yeah.
of standardized in a way that you can show in a YouTube video. So I
Wow.
think it creates some kind of
Well, it creates
difficulties
yeah,
for us.
obstacles, but
Yeah.
opportunity also.
Yeah. And we have to think about information a little differently and
Very
how we
cool.
talk to people about what it'll do.
Dr. Callahan, thank you so much for dropping by, and congratulations on this great work.
Thank you so much.
Thank you.